Hello, future doctors. How are you all? Welcome back to MedSteps YouTube channel by Dr. Anand. So today we are going to learn one of the most important obstetrics investigation, the thing we call cardiotocography or CTG. So CTG is not just a mission; it producing lines on paper. It is actually the baby's voice before birth. So the baby can't tell us if it is getting enough oxygen or not, but the heart rate can. So whenever you look at the CTG, imagine the baby is talking to you through its heartbeat. So by the end of this lecture, you will able to understand every CTG component and how to interpret it confidently and identify the fetal distress early and decide when to do reassurance is enough and when urgent delivery is needed. Okay, so without time waste, let's go. So first of all, you can see here that is from little basics we will learn, then after we will go forward. So what is CTG? CTG stands for cardiotocography. Okay, so it continues records fetal heart rate. It continues records fetal heart rate and uterine contraction. So fetal heart rate, you can see here. This is the that heart rate of the fetal, and here you can see mother contractions. So this is mother contractions. Always, whenever you are seeing CTG, we have to compare with heart rate along with contractions. Okay. So next, think of CTG as monitoring two patients simultaneously. One is the baby fetal heart rate, another one the mother like uterine contraction. So why do we perform CTG? The main purpose is to answer one important question: is the baby receiving enough oxygen or not? If oxygen decreases, the baby's heart rate changes before permanent brain damage occurs. So that is why CTG helps to detect fetal hypoxia early. Okay, so here, if you are seeing here the paper speed, the main the strip, the speed, you can see that is 3 centimeters per minute, and we can see the fetal heart rate will be like 50 to 210 beats per minute, and uterine contraction will be like 0 to 100 mmHg. Okay, so next we can see here that is what to assess in order, how to do the CTG interpretation. So before that, why we are performing CTG, we discuss that thing. When do we use CTG? Examples like if any patient came with high risk pregnancy or reduced fetal movements or labor induction, or if patients have severe preeclampsia and patient have any diabetes or meconium, staining, liquor and vaginal bleeding and oxytocin augmentation and previous cesarean section, then we have to do CTG. CTG is the main thing to find out the problem with mother and baby. So before interpreting CTG, never jump directly into interpretation. Always we have to check with the gestational age, and while doing ultrasound, we can easily look that based on some lambda sign and T sign, we can differentiate that is monozygotic or dizygotic, like twins are normal. That thing we have to know. And mother having fever, and is she receiving any oxytocin, and the membranes are ruptured or meconium is present. So these are the main things we have to know before doing CTG interpretation. So we have some golden steps to interpret CTG in order. So first one you can see here, that is baseline fetal heart rate. We have to check. Next we have to go with variability. Okay, acceleration and deceleration and uterine contractions. We will go step by step. So never change the order. If you can't remember this thing, I have one mnemonic, that thing we called BADC. Okay, B means baseline, V means variability, A means acceleration, D means deceleration, and C means contractions. So always we have to follow this order. Okay, so first of all, always assess in this order to avoid missing important information, because in OBGYN ASCII settings or Viva setting, the doctor will give this type of strip to interpret it. Okay, if you are not interpreting properly, they will take out your marks. So that's why it's very important. Next, we can go individually. Okay, so first of all, we can see here that is first one, baseline fetal heart rate. Baseline fetal heart rate, if you're seeing here, that is baseline fetal heart rate means in average fetal heart rate over 10 minutes. In 10 minutes, the average fetal heart rate we are going to find out. So in normal, the heart rate will be like 110 to 160 beats per minute. Think of baseline as the baby's resting heart rate. Okay, so here you can see here that is fetal tachycardia. In fetal tachycardia, the heart rate will be like greater than 160 beats per minute. And for fetal tachycardia, I have a mnemonic that is fast baby. So what are the things? What are the main causes will cause fetal tachycardia means like fever, anemia, sepsis, and thyrotoxicosis. In baby, we can see like fetal infections, hypoxia in early cases, and drugs. For example, mother has chorioamnionitis. The temperature will be like 39 degrees Celsius. The baby fetal heart rate will be like 175 beats per minute. The main diagnosis is fetal tachycardia due to maternal fever. So like that we have to know how to interpret it, how to the causes and everything we have to know. Okay. So next we can go with fetal bradycardia. Fetal bradycardia will be like less than 110 beats per minute. So if below 110 beats per minute means we have to suspect some like fetal problems, like low heart, like cord prolapse, severe hypoxia, um, maternal hypertension, or epidural, or uterine rupture. Okay, for example, cord prolapse occurs, so the baby heart rate suddenly falls to 70 beats per minute. Then we have to do emergency delivery is required for this type of condition. So this is the baseline, and based on that baseline you can find out that um, fetal heart rate. Okay, next you can see here that is baseline variability. So variability means what? This is the most important part of CTG. Variability means it's like small beat to beat fluctuations around the baseline. Simple. So think of it as the baby's nervous system talking to us. So a healthy baby never has a perfectly straight line. So normal variability around we can say like 5 to 25 beats per minute. Okay, so if any fluctuations in fetal heart rate, that thing we called fetal heart rate amplitude, that thing we call variability. If the variability, um, okay, so normally if I'm telling variability, you can't understand. So imagine like two students. Student A always serious, never smiles and never react. The student B will be like always laughs, talks and responds. Which one looks healthier? The student B, right? Because he's laughing, talking and responding. So similarly, in a CTG with variability looks alive. So a flat CTG is concerning. Simple. Okay. So in variability, if it's reduced means like less than 5 beats per minute. So if less than 5 beats per minute, then in this greater than like 40 beats per minute, greater than like 40 minutes, you are seeing like less than 5 beats per minute of reduced variability, then we have to suspect the baby sleep in sleep cycle you are doing CTG, a low oxygen or extreme prematurity, and like some exposure to drugs like opioids or magnesium sulfate or pathologies like acidosis. Okay, so if it's more than 25 beats per minute means okay, no problem. If it's absent means we have to take concern. Okay, we have to look it after. So these are the things. So this is 5 to 25 beats per minute is the baseline, like normal variability. Next, you can see here that is acceleration. This is very important. So accelerations means it's like a temporary increase in fetal heart rate, like healthy baby or happy baby, well oxygenated baby, or think of accelerations as the baby waving at you. Now we have one rule that is if increased, okay, this transient increased in fetal heart rate above baseline, then we call that is acceleration. So if increased greater than 15 beats per minute for greater than equal to 15 seconds after like before 32 weeks, before less than 32 weeks, we have to see this acceleration. Okay. Next, if greater than equal to 32 weeks, the we can see the okay, the heart rate will be like greater than equal to 15 beats per minute for greater than equal to 15 seconds. Okay. So what we have to do, if greater than, if before 32 weeks means, it's mistake here, before 32 weeks means we have to see 10 beats per minute for 10 seconds. Sorry, it's a mistake. So for less than 32 weeks means we have to go with 10 beats per minute for 10 seconds. Okay. So for example, baby moves, heart rate rises from 140 to 160 beats per minute and return to baseline. So it's like perfect reassuring. Reassuring is the main important. So we have to do reassurance in acceleration. But always in acceleration, we have to compare with the less than 32 weeks and greater than equal to 32 weeks. If less than 32 weeks means it's like 10 beats per minute for 10 seconds, and greater than more than 32 weeks means like greater than equal to 15 beats per minute, greater than equal to 15 seconds. Okay. And we have one mnemonic like movement. Movement means music. The baby is moves, so the heart will dances like that. It's like I when I'm doing CTs, that time I learn like this. Okay. So next we can see here that is deceleration. In deceleration, these are the temporary decreases in fetal heart rate. Below the baseline it will go. Okay. So in deceleration, not all decelerations are dangerous. We divide them into 4 different types. Okay. One is early. Early means it's near early deceleration. If you are saying means it's related to head causes like head compression are occurring during contractions or mirror image of contraction, um, are benign. Or example like second stage of labor, baby's head descending, or early deceleration sign are normal findings. Okay. So that is early deceleration. So next we can see here that is variable. Variable, if we are getting any variable type of deceleration, we have to suspect patient have cord compression. Okay. So variable means you can see this thing is slouching, right? So but variable means it will comes like a V type structure you will get. So that is we call variable. In variable, in late in variable deceleration, if you are getting means the patient, the baby have like umbilical cord compression, sudden onset or sudden recovery. So it looks like a V or U or W shape. Okay. So it may improve by changing maternal position. Example like cord wrapped around baby's neck or variable deceleration appears. Okay. So next you can see that is late deceleration. Late deceleration means this is the most important one because in late deceleration it's related to um, placenta. Okay. Um, it's related to placenta. Are the main causes it in late deceleration. We can see like uteroplacental insufficiency starts after contraction begins and ends after contraction end. So the dangerous is baby not receiving enough oxygen. So the common cause we can see like uh, preeclampsia and diabetes and postpartum pregnancy, and placental insufficiency. So, for example, contraction occurs, the heart rate falls after contraction repeated late deceleration. So, the diagnosis will be like a fetal hypoxia. Okay, so next one, last one we can see, that is prolonged deceleration. If the heart rate greater than if the heart rate decreases like greater than equal to 15 beats per minute, the lasting will be like 2 to 10 minutes. The main causes we can see cord prolapse, maternal hypertension, and uterine hyperstimulation, and placental abruption. Okay, so these are things we can see. At last, we have to see the contractions in step 5. So in contractions, we can see here the contractions will assess like frequency and duration and intensity. So we have to check in mother's strip, like uterine contraction strip. Okay, mother contraction strip. So in normal contractions, we can see 2 to 5 in 10 minutes. Okay, so 2 to 5 contractions in 10 minutes, that is normal. Next, we have tachysystole. In tachysystole, we can see more than 5 in contractions in 10 minutes. So usually caused by like oxytocin, or in danger like a baby has no time to recover between contractions. The management will be like to reduce to stop oxytocin. So next we have another thing, that is we call hypertonus, like greater than 90 seconds. We can say greater than 90 seconds. Resting tone will be like greater than 20 mmSc. Okay, so this is the uterine contractions. Now we are going to divide CTG classification. Based on that, we are going to treat that patient. So CTG classification, also known as, we have some category. Based on that categories, we are treating patient in GPHC. Okay, so first of all, we can see here CTG classification. In that CTG classification, we call that is NICE guidelines. So based on that color, I'm going to interpret it. So first one, you can see here, um, green color. Green color means it's like a normal case. In normal case, like everything like baseline, variability, and deceleration. Okay, and that acceleration, and the heart rate, everything is normal. So for example, the baseline is 110 to 160 beats per minute, variability 5 to 25 beats per minute, no pathological decelerations, and with or without acceleration, and uterine activity is normal. Then what we have to do? Continue routine care we have to do. Okay, so that is normal category. So next we can see here, that is yellow means intermediate. So if you are seeing like in one suspicious features, like we have to observe closely, and we can correct this thing reversible. Like what are the things we can see in intermediate in CTG? Like we have total 3 categories. So this is category 1. In category 1, we can see like the baseline will be like 100 to 110 or 161 to 180 beats per minute. And variability, we can see it will reduce for less than 40 minutes. Okay, or moderate variability, with or without no acceleration, with normal variability, and single variable deceleration we can see. Okay, single variable deceleration, or with or without early deceleration. Then the main thing what we have to do, it's like normal, and we have no intervention is needed. So just we have to increase surveillance, and we have to correct reversible causes. Next, you can see here, that is orange one, that is multiple abnormal features. You can see here, and we have to take, if we are getting this type of abnormal review, we have to take review from senior doctor, and we have to consider delivery. So in category 2, like abnormal CTC, we can see some baseline like 110 to 109, at 161 to 180 beats per minute with reduced variability, and we can see recurrent variable decelerations, along with that any late deceleration. So these are the category 2 is very important, because it can go to It's maybe it's not, it can go to category 1 or category 3. So what we have to do, we have to review urgently with senior doctor, and we have to consider expedited delivery, and with or without examination we have to do close follow up, and we have to consider supportive measurements. So at last we have category 3, that is pathological. So in pathological, the CTG will be like we have to do immediate action, and we have to prepare for emergency elective cesarean, like emergency delivery. So here you can see baseline will be like less than 100 beats per minute, and reduced variability, okay, or absent variability, or it will be either, and we can see greater than equal to 40 minutes, and we can say like absent variability with any deceleration. Any decelerations means maybe it's like recurrent late deceleration or recurrent variable deceleration, we can see. Next, in some cases, severe cases like bradycardia. Okay, in severe cases we can see sinusoidal pattern also. Sinusoidal pattern means the patient have, the main cause will be like severe fetal anemia. So what we have to do, we have to do management of C-section. Okay, so we have to do C-section. So if patient have sinusoidal patterns or this type of category 3 features, what we have to do, we have to do proper physical examination, we have to change maternal position, we have to give proper oxygen. Next, if mother getting any discharge or labor augmentation, if you are giving tocolytics, we have to stop. Next, we have to give some fluids to correct hypotension. Then after, we have to consider for C-section. So we have to do immediate review to the senior doctor and prepare for urgent delivery. So next, in deceleration, we have different types. Based on the deceleration, we are going to treat that patient. In early deceleration, it will be like mirror image, same to same like uterine. With if you're comparing with uterine contractions, the deceleration will be like same to same. Okay, it will like start nadir and end with contraction, and it's caused by fetal head compression and benign. We already discussed this thing. So next variable, vary in shape and depth duration. It will abrupt onset and recovery due to cord compression and may be benign and concerning. So next we can see here that is late deceleration. It's like gradual onset and recovery. Nadir after contraction peak and due to uteroplacental insufficiency and concerning. Next we can see that is prolonged deceleration, that it will decrease greater than 15 beats per minute, and it lasts greater than equal to 2 minutes but less than 10 minutes, and it's usually due to acute hypoxia and concerning. Okay, so these are things, main important things. So here we have some advanced points for exam point of view. Okay, so the thing we call stand analysis, like Saltelli. Saltelli means like short-term variability, transient deceleration and accelerations, and number of fetal movements we can see. Next, you can see that is sinusoidal pattern, like smooth, regular and wave-like pattern. You can see that is 2 to 5 cycles per minute. And it's associated with fetal anemia and hypoxia and drugs. We discussed already. Next one, fetal tachycardia causes like maternal fever, infection, anemia, drugs, hyperthyroidism, and fetal distress. Next, we can see that is fetal bradycardia causes like hypoxia, cord prolapse, drugs, and heart head compression. Always we have to correlate with the clinical picture and maternal conditions. So a good CTG is reassuring, but a bad CTG is a call to action. So in simple, we have that category, right? So this category is very important. So that's why like we have to know this like what are things we discussed today. So in simple table form we will discuss another time. That is baseline. In normal cases, the baseline heart rate will be like 110 to 160 beats per minute. Variability, as you know, 5 to 25 beats per minute. Next, acceleration, it will be present or absent. Deceleration will be like none, and the uterine activity will be like 2 to 5 contractions in 10 seconds. So this is normal. In abnormal, you can say like 100 to 110 or 161 to 180 beats per minute. The fetal heart rate. The variability like less than 5 beats per minute for less than 40 minutes, or 25 beats greater than 25 beats per minute in less than 40 minutes. It's like abnormal. And in acceleration, we can see absent with normal variability. The deceleration will be like variable or late. The uterine activity will be like greater than 5 in 10 beats per beats per 10 greater than 5 in 10 minutes contractions or hypertonus. Next, we can see pathological. Pathological will be like less than 100 beats per minute baseline fetal heart rate, and the variability will be like less than 5 beats per minute for greater than equal to 40 minutes are absent. Next, we can see accelerations like absent with abnormal variability. Next, you can see decelerations like recurrent, late, prolonged, or bradycardia. Next, we can see at last that is uterine activity like sustained hypertonus with fetal changes. Okay, so these are the main things we have to know. So next, if patient have any problem with intrauterine resuscitation, how to do management means we have some methods to treat late recurrent variable deceleration by increasing oxygen delivery to fetus. So for example, if you're suspecting the mother getting inferior vena cava compression, we have to roll to left lateral decubitus position to mother. Next, if you're suspecting the cause will be like hypotensive, we have to give intravenous fluids. If we are suspecting uterine tachysystole, we have to stop oxytocin and we have to consider terbutaline. And if it's like oligohydramnios or cord compression, we have to do amnion infusion. And if everything fails, then at last we have to do C-scan, C-section. Okay, so this is the things. Mostly we covered everything in like CTG. So this CTG like episode 1 in obstetric gynec series. So we will meet in our next videos, in upcoming videos. If you didn't subscribe my channel, if this video is helping you, so please subscribe my channel. If you have any doubt, you can ask me in comment section, and you can follow me in Telegram and Instagram. Okay, so in Instagram the username will be like Dr. Anand. So Dr. Anand Jana, so you can follow me. Okay, so we will meet in our next video. Till the time, take care. Bye.